This is Dr. Praveen Bitoy from the Department of Anesthesia at Western University. This video presentation is intended for the use of third-year medical students at Western University who will be undertaking their surgical rotation, which will include a 2-week stint in anesthesia. This presentation is to discuss spinal anesthesia and epidural anesthesia. This slide captures the essential differences between the two. There is no need to delve into much detail with these slides, as I will discuss them later on in the presentation. Our learning objectives today will be the following. We will discuss the anatomy of the spinal cord as well as the vertebral column. We will look at the differences between spinal and epidural anesthesia, and we will talk about the indications and contraindications to both. We will also consider the side effects of both. This slide discusses the surface anatomy as viewed from the posterior aspect of a patient. Note that if you draw a line between the lower blades of the scapula, you should be crossing the T7 vertebrae. If you place your hands on your hips, you would be placing your hands on the iliac crest. Remember, this is the posterior part, and if you draw a line between the two, you're typically crossing the L4 vertebrae or the L3-L4 interspace. The line that joins the two posterior superior iliac spines and their sacral hiatus forms an equilateral triangle. These landmarks are used in the performance of caudal blocks or caudal epidurals. These are usually done in the pediatric population. This slide shows a sagittal view of the vertebral column, spinal cord, and surrounding tissues. The red arrow shows the posterior aspect of a patient and points to the skin. Now we look at the spinous process. Here are the interspinous ligaments. This is the spinal cord. Note that if we are seeing the spinal cord, we must be at the L1 level or above. The CSF or cerebrospinal fluid surrounds the spinal cord. Ligamentum flavum is an important landmark. This is an artistic rendition of the previously discussed slides. Note that in this diagram, the patient's back would actually be to the left of the slide as compared to the right of the slide in the previous set of slides. If we were to strip everything away but leave just the vertebrae and the ligaments, this is what we'd see. The yellow arrow points to ligamentum flavum, which is colored yellow in this slide. Notice that ligamentum flavum is V-shaped. This is also the posterior border of the epidural space. Number 2 is the interspinous ligament. This joins the spinous processes. This would be the ligament that your needle would go through if you are performing a spinal or an epidural. The yellow arrow points to this ligament, which is colored blue. Number 3 is the supraspinous ligament, which joins the posterior surfaces of the spinous processes. Again, if you're performing a spinal or epidural, this would be the first ligament that your needle would be going through. Number 4, the yellow arrow points to the transverse process. It would be unusual that your needle would contact the transverse process. If it does, it means that you are off midline and that you need to redirect your needle. This depiction is of a cross-section through the L3-L4 interspace. The posterior part of the patient is depicted by the green arrow, which is at the lower part of the slide. Notice the subcutaneous layer of fat. The intervertebral disc is clearly seen, and notice how closely applied the aorta is to the anterior part of the vertebral body. The green arrow points to the filum terminale. Note that because we are at the L3-L4 level, we will not see the spinal cord at this level in an adult. Feel free to pause the video at this point or to refer to the actual PowerPoint presentation if you would like to read all the other labels. The green arrow is pointing to the epidural space. There are both blood vessels and epidural fat in this space. Notice the posterior border of the space is ligamentum flavum, which is yellow colored in this case. The maximum amount of space available is 5 mm from the posterior part of the ligamentum flavum to dura. If you are midline, you will achieve this 5 mm space. If you are off midline, you might have slightly less space. This is a magnified version of the previous slide. It is included just to highlight the detail discussed previously. I will discuss CSF anatomy very briefly. Further information is available in any of your standard medical textbooks. The CSF is produced in the choroid plexus. It is absorbed by the arachnoid villi. Our production per day in an adult is 600 to 700 mils. Note that at any particular time we have anywhere between 140 and 270 mils in an adult. So this is the volume of CSF that we all carry around. CSF has four main functions. The first is protection. The CSF acts as a shock absorber. This is really helpful when we bump our heads lightly. Clearly, if you have significant trauma to the brain, you need more than CSF. The second is to supply nutrients to the brain as well as to remove metabolic waste. The third is for cerebral autoregulation. This is done by controlling the volume of CSF in the cranium. If we have high intracranial pressure, the CSF is moved down into the spinal space. The fourth and perhaps underappreciated function of CSF is buoyancy. The human brain weighs approximately 1.4 kilos. However, when it is suspended in CSF, the effective weight is approximately 25 grams. This is quite a huge reduction. This is important because if it was not for this, then the upper part of the brain would compress the lower part of the brain, which would then decrease the blood supply or perhaps even cause neuronal death. So what is the difference between a spinal and an epidural? The diagram on the left shows a spinal, the diagram on the right shows an epidural. Note that with a spinal, we would be injecting our medication, in this case local anesthetic, into CSF. Thus we would be going through dura as well as through arachnoid. As you know, arachnoid and dura are usually inseparable. On the right hand side we find that we have a catheter in place, but this catheter is actually outside the dura in the epidural space. It is unusual to place a catheter in the spinal space. That means it is unusual to place a catheter in CSF. This may occasionally be done in specific circumstances, but for the most part, spinals are single-shot injections. On the contrary, it is quite unusual for us to have a single-shot epidural injection. For the most part, we do place an epidural catheter so that medication can be given via this catheter for as long as it's needed. The most common use of epidurals would be for labor, where we know labor lasts anywhere from a few hours up to even 36 hours. We also use epidural catheters for post-operative analgesia. As we know, we might keep an epidural in place for up to 5 days following surgery. So what are the physiological effects of both spinals and epidurals? Note that both have similar effects. The speed of onset of physiologic effects would be faster with spinals. What we desire with either of these blocks is we desire a sensory block, as we are usually using these modalities for pain control. However, we do have an associated motor block as well as an associated sympathetic block. Of significance with the sympathetic block is that it can be up to 6 segments higher than a sensory block. With a sympathetic block, what we would notice is that we would see vasodilation below the level of the block. Vasodilation would mean blood pooling below the level of the block, which would then lead to hypotension. If a sympathetic block is high enough, that means if it reaches the cardiac accelerator fibers, which usually are the thoracic vertebrae T2 to T6, we might see bradycardia. Bradycardia results because of unopposed vagal stimulation. Vasodilation means that blood is flowing close to the skin surface. This results in a loss of heat, which subsequently results in a decrease of core body temperature. The body's defense to a decrease in core temperature is to vasoconstrict, something that cannot be done because of the sympathetic block. The other defense is shivering, again, something that cannot be done because of the motor block. Those parts of the body that are above the block are not affected by this. Patients who have an epidural or spinal may sometimes complain that they find breathing difficult. This is not really true, as their breathing is well maintained, as most of the breathing is done by the diaphragm. What does happen is that because they have a sensory block at the level of the chest wall and the brain does not sense the chest wall moving, it interprets this as difficulty in breathing. Reassurance is all that is needed in this case. Clearly, if the block extends high enough, that means if it extends up to the C2 level, which would then block the phrenic nerve, would be an emergency. This patient would then need to be intubated and ventilated. If the motor block extends to the intercostal muscles or to the accessory muscles of respiration, which are usually not used in quiet normal breathing, but may be important in somebody who has COPD, as they might require these muscles for active exhalation, these patients might then complain that they have difficulty in breathing, and in them it would be significant. Diagrams showing dermatomes are available everywhere, and certainly you could all have one on your phone. The contraindications to both spinals and epidurals can be divided into two main categories. The first might be termed strong contraindications, and the second might be termed relative contraindications. The strong contraindications might also be called absolute contraindications, and they would be things like patient refusal, if the patient has been recently or is currently anticoagulated, and if a patient does have raised intracranial pressure, performance of a spinal or an epidural, if CSF is released in this case, might be the cause of brainstem herniation. The relative contraindications are listed as skin infection, systemic infection, hypovolemia, inexperience of the operator, and pre-existing neurologic disease. The side effects of epidural and spinal are similar. There are numerous potential side effects or complications, and we will discuss this during our lecture in class. Do we have any control of the duration of spinal? Yes, we do, but the extent of control is fairly small. The dose of drug would affect the duration. More drug, which would mean longer duration. More drug meaning more molecules, which would then mean it takes a longer time to redistribute these drugs or metabolize these drugs, which would result in a longer lasting spinal. We also use longer acting local anesthetic agents versus shorter acting agents. The most commonly used long acting agent would be bupivacaine. The short-acting agent sometimes used would be lidocaine. We could also add adjuvants to the local anesthetic to prolong the duration of action, and the adjuvants listed are epinephrine, phenylephrine. There is some synergism with narcotics. We have also used clonidine and neostigmine to prolong spinals. This question is not relevant with regards to epidurals, as an epidural would last as long as we keep the catheter in and as long as we infuse local anesthetics through the epidural catheter. The other main question asked of spinals is, how do we control the height of the block? There are two methods that we use to control the height of a block. The first is, again, the total dose of drug. More drug, which means more molecules, which would result in a higher block. The second, and perhaps more important, is the use of hyperbaric versus isobaric medication. Hyperbaric medications will tend to move with gravity. Thus, we use a hyperbaric agent and we can keep a patient sitting for a longer period of time, which will then result in a block that stays low. If we wish this block to spread upwards, we lie the patient down immediately. If we lie the patient with head down, we can see that hyperbaric medication can drift towards the head and thus can result in a very high block. Isobaric medications tend not to spread but tend to block where the injection is given. As mentioned previously, epidurals last for as long as we keep the catheter in place, and we may keep the catheter in place for usually days, but it can be kept in place for weeks for patients who have chronic pain. The epidural has synergistic effects when opiate is added to a local anesthetic mixture. This is our usual practice in London. How do we control the spread of an epidural? For the most part, for an epidural, we site the catheter in the dermatome that we are attempting to block. If a patient is having a laparotomy, we usually site the epidural in the mid or low thoracic region. If a patient has an epidural because of labor pain, we site it in the lumbar region. If you refer to your dermatome diagrams, you'll be able to see why these sites are chosen. The other way to control spread of an epidural is the amount of drug or volume of drug administered. Clearly, if a small amount of drug is administered through the catheter as an infusion, there will not be widespread from the tip of the catheter. However, if the drug is infused at a high rate or a large volume is injected through the catheter, we will have spread quite a few dermatomes beyond where the tip of the catheter lies. Thank you for watching this video, and I hope that you have learned something from it.